Um, I'm Steve Sawyer. I'm the founder of the Developmental Trauma Training Institute and the developer and writer of the Digging Roots Foundations course, and then also that is also used as a pre-course for those of you that are trained in brain spotting. We have Digging Roots 1.0 for brain spotters and 2.0. So there's a total of three trainings. And here to just give some introductions, some things to think about, have a conversation with those of you. I want to talk about some developmental trauma, ask questions after I present some of the research and information that we share across the country and worldwide that differentiates developmental trauma experience from other forms of trauma. I am a trainer for multiple organizations, developed Developmental Trauma Training Institute a year and a half ago. After working for 18 years, working with severely developmentally traumatized teens and young adults in our trauma responsive wilderness therapy program. Those clients taught us a lot along the way, and many years of work with them led to a lot of what is built into this course. We're really excited. We are launching in about a month here. We're launching the Digging Roots Foundations course, which is for all therapists and regular people that want to explore their developmental trauma. We have cohorts, people that are out there that want to learn more about their developmental trauma can go through a standard cohort, and then there's clinical and professional cohorts. So these are opportunities to learn, to explore more about developmental trauma, and lots of exercises in there to discover, to remember, and to learn. Uh, so Developmental Trauma Training Institute is where I put most of my time and energy now. I'm also a trainer for White Bison Incorporated, which is a native-focused organization that I train Mending Broken Hearts curriculum for, which is a curriculum for healing native grief and historical trauma. And have been training that for the last last year and a half. I'm also a brain spotting phase one, phase two trainer, and then the developmental trauma model developer. And I also trained for the Institute of Heart Math. I was part of writing both of their curriculums, the Heart Math Interventions program, and also the Heart Math Resilient Heart Trauma Certification program, which has gotten lots of positive feedback and was an incredible project with experts like Dan Siegel, myself, Thomas Hubel, the Gottmans. So lots of information in this. This will be pretty focused on some of the research that was actually uh, passed on to me through Joseph Spinazzola, who was previously the executive director of the Trauma Center of Boston. And we, back in the day, did a campaign to heal childhood trauma down the East Coast and across central United States, where we presented this research and some of the needs for change in the mental health world to recognize developmental trauma as different from other forms of post-traumatic stress disorder, complex trauma. We're going to lay that out actually tonight, some of that for you. So that's what we're here to do. I wanted to give a moment for other members to introduce themselves, especially Aaron here.
Welcome, everybody. My name is Dr. Erin Findley. I'm a psychologist here in Napa, California, otherwise known as the unceded lands of the Wapo and the Winton Patwin tribes. I am super excited to be here. I've been with Steve since the beginning of the Developmental Trauma Training Institute, and I'm currently serving as the training development director. So I'm the one who's helping get all this stuff organized and shaped up. And I'm also a trainer in training for this topic as well. So super excited to be here. I'm also autistic, ADHD, and gifted. Yeah, so super excited to be here supporting you all.
Thank you, Aaron. Aaron will help me too with monitoring the chat as things come up, and we
You bet.
can pause along the way. Don't be afraid to raise your hand if you have questions that come up, and I'll work through them. Uh, In this discussion, I do want it to be a discussion for people to explore things that come up along the way. So as you raise your hand or put questions in the chat bar, when it feels about the right time to answer, stop and pause and cover some of those, Aaron will let me know. So we'll pause and take a look at any of the questions that are coming up. This topic, is exciting for me and equally sad in that the developmental trauma research was proposed to the APA, the American Psychological Association, for a new diagnosis, developmental trauma disorder. Those of you that follow me closely know I'm not a fan of talking about disorders. I like to talk about trauma adaptations and manifestations. But for our mental health world to recognize it, the unique attributes of developmental trauma is a very needed evolution. And unfortunately, uh, despite pretty extensive research, the APA turned it down and decided research needing more research. In my frustration and Bessel van der Kolk's frustration, Joseph Spinazola's frustration, we, Joseph reminded me that it took 15 years of work to get PTSD, post-traumatic stress disorder, identified as a diagnosis. And hopefully it doesn't take another 15-year journey for us to be able to see and recognize the differences that are pretty clear to, especially the professionals that are out there. But this information is valuable for anybody who grew up in childhood trauma or wants to understand more about it. It's not just for professionals to understand. PTSD has become a more widely accepted and known and understood manifestation, but developmental trauma's, unique attributes are something that is really important to spread the word on. And so please, follow us. This is a free event that connects you to us. But I do Facebook Lives every Tuesday morning on the Developmental Trauma Training Institute's Facebook page. Follow us there. I talk about a lot of the attributes of these things every week. We also have the manifestations of acute stress response happening right now with lots of things happening in our world, environmental factors, political factors, war, etc. And all of these things impact our sense of safety. And a lot of our initial development of safety comes in the early developmental years. And so that's why this information is so important, because people that did not have attributes showing from their early childhood trauma are commonly seeing them now. As stress goes up, these attributes get louder and manifest themselves. So we're going to talk about some of these attributes tonight, get into some questions, and I'm going to get the PowerPoint started here for you all. Okay, it wasn't giving me that as an option to start sharing, so we'll try that again. Here we go. So, well, I got some dates that are still old on there. But in that, to recognize digging roots, to talk about that for a moment, one of the things that I like to talk about is a quote, and I mean we have in the training actually, that often we're looking amongst the leaves and branches for what actually lives in their roots. And so when people are coming in for help and they have long histories of developmental trauma, oftentimes there's some form of attribute that's at the surface that they can see, that others can see, that brings them in. But what's driving that process is early developmental trauma. And that's the metaphor that digging roots comes from, that we're looking deeper below the surface in history and examining carefully what really lives there to be able to get a more thorough healing journey and process and even wisdom. so often people are perplexed about why they struggle later in life. And in that, we really seek to reveal the roots of where all this lies. And the research often helps in supporting and doing that. So before I move forward, I always, acknowledge really important things before I get started. First of all, to acknowledge the elders that have contributed and shared their time, energy, and teaching with me. Uh, I acknowledged Joseph Spinazzola and his research, along with Bessel van der Kolk. Their organization really led the forefront of the research in this work for a long time. That research organization has now been disbanded and slowed down. Those individuals taught me a lot about developmental trauma. Uh, in that, there's lots of trauma elders. I'll show them in a moment that really took the time to teach me. I'm also neurodivergent. And for me, I have to be walked through experientially or have deep discussions to pull research apart and get into the details. And there's been a lot of contributions in this training, including the time and the work with the model with Gabor Mate. And we've done 6 panels across the country together, sharing about developmental trauma and its ties to addiction also. Others that were along the way, Dr. David Grand taught me a lot about the nervous system, and he's the founder of brain spotting therapy. Not everybody on here is brain spotting trained, but in that it's an extremely effective model that is great for working with developmental trauma because it focuses on physiology. One of the toughest things about treating developmental trauma is that oftentimes people don't have a lot of memory related to their early childhood experience. And a lot and the majority of modalities that are out there are focused on memory-based work. And so brain spotting has been huge in that way and has led to extensive healing for myself and many others with developmental trauma. Those are some key contributors. There's some neuroscientists and things I'll show in a moment, but this work and the stuff I present isn't mine to own. It's really been gifted to me through other elders and researchers and understanding and people spending time with me talking about developmental trauma particularly. And then my ability to put the story together with thousands of client hours, particularly in the woods with people with developmental trauma, led to this model. So not just to acknowledge elders, but the youth and the clients that were the foundation of learning how to treat more effectively based upon this research and the findings that are in it. I always acknowledge that I'm light-skinned, I'm blue-eyed, blonde-haired. I am a native man in our Lakota language. I'm an Iyeska, I'm a mixed blood. In that, I always introduce myself in our Lakota language and say, Hanhapi Washtelo Dokia Ta'oa, Ikshewi Chasha Wakianashnala Naji Machiape, Mia Chante Tiana Napuzate. I greet each of you with an open heart and a handshake. In that, I'm also a male, I'm a cisgendered male. And these things, along with education, have, granted me privilege throughout my life. And with that understanding, if there's something inside of this that offends you somehow or bothers you and how I present something, please feel free to inform us. I also always say, Ishtunaha, open my eyes. So I can see the world a little bit brighter, a little clearer, with a higher understanding. To acknowledge the land for me, I travel a lot, as Nancy was mentioning before, but I am actually at home in Bend, Oregon. And here I sit on the land of the Paiute Nations, the Wasco tribes, we're the primary users of this area, but our Native people don't really believe in land ownership. So even land acknowledgement as a land of, these are territories that were shared amongst many tribes. People commonly migrated and went through various areas of land and shared space and traded or brought a gift to be able to go and hunt in an area or harvest plants in a particular area at a time when it was time to harvest. And so it's shared land. But in that, we appreciate the acknowledgement of our native peoples, but often done in a way where it implies land ownership. The other part of it is to acknowledge the land, is to acknowledge the history and the true history, and our history with our native people here in this country is quite dark. And I often will spend more time there, but I just encourage people to make sure if you acknowledge the land and the native tribes around you, that you inform yourself of the history of the events, the attacks, the conflicts, the massacres that have happened on this land, and not ignore them, and to acknowledge that along with it, because when we acknowledge the land, we actually acknowledge our ancestors. So that's just a little bit of ground to cover before we get started. To share a little bit more about elders in my life, these are a lot of elders that have shaped my world. My adopted dad, Chief Wakion Snamani, or Michael Littleboy from Pine Ridge Reservation, upper left. My grandmother, who waited till she was 80 years old to reveal her truths of being an adoptee into a white family as a Native woman. Um, uh, Multiple elders from the White Bison and Wellbriety movement. Sparrow, Albert is there, Albert Titman from Sacramento, and Don Coyas, the founder of White Bison and the Wellbriety movement. Gene Thinelk there. I got to spend some time with him just a couple weeks ago. My father is on the far left. He was, a man who taught me how to harvest from the land in a respectful way, and also Lou Redmond there, who taught me some of the most about shame. Four-star Army General Mohawk from the whole Mohawk Nation, who taught me about self-compassion. Trauma-wise elders, I've had some good ones. I don't know why me. Don Coya said that to me last year. He said, quit asking why, just say next, Steve. I get walk amongst some very potent trauma elders. Me and Gabor were just up and did a project up with the Mohawk Nation up in Upper Canada just about 4 months ago now. There on the left, David Grand there in the middle. Neuroscientist Demir Demont spent some time talking with me about the use of eyes and stress response and key elements in the brain and brain structures that do that, and I'm not going to spend too much time there. There's Joseph Spinazzola, myself, and David Grand presenting at one of the institutes on the East Coast on some of this research and understandings. There's Bessel, and then Stephen Porges. I've had some time to sit and talk with him about the manifestations of how trauma response works, and particularly looking at how the therapy of brain spotting works with that. So those are all people that contributed to my knowledge to go on and pass on to you. Some helper introductions there. This is an old and needed update, but there's Aaron there, and Chris was a part of our journey early on. Before I go into talking about behavior, diagnosis, attributes of trauma adaptations, I always like to start by acknowledging that people and children alike, in my world, there are no bad kids or bad people, just impressionable, conflicted young people wrestling with emotions and impulses, trying to communicate their feelings and needs the only way they know how. And so in that, when people come to us for help or support, or people act up when they're a child, we do that based upon impulses and emotions that we've been taught to manage in particular ways or not taught to manage. So in that, it's really easy to start looking at childhood trauma through a lens, a behavioral lens, and I look at it through a different compassionate lens. The other thing, when I start to talk about trauma, we have these things, these wrestlings, these struggles, but also one of my taglines on my personal website is that where all trauma exists, resilience is lurking. And oftentimes, people have to survive early childhood trauma. While they're doing that, there are also forms of resilience that are there. I do not believe in a fragilization of developmental trauma populations. These are some of the most resilient people on earth. It doesn't mean they don't struggle. It doesn't mean that there's not challenge in their life that pops out on and off throughout the lifetime, but the ability to acknowledge them for their strength and their capability to adapt in these environments, various forms of support they might have utilized, etc. And then some of these manifest in unhealthy processes down the road that need to be addressed. But next to all of these trauma experiences, are also pockets of resilience. I'm a fan of Alan Francis's contribution to the therapeutic world, Saving Normal. It's his book, An Insider's Revolt Against Out of Control Diagnosis. And he was one of the authors of our diagnostic manuals for mental health. And he directly in that book states that this was never what it was designed to be used for. And the misuse of it, something that he's speaking out against very avidly at this point, and serious contribution to take a look at when we start to talk from trauma adaptations and pathology lenses. The ability to look at each person as an individual manifesting in their own individual ways is part of that story. And we do need to be able to have conversations in a healthy way, but our mental health world particularly has went extremely into the direction of pathologizing and diagnosing. Well, I see your hand there. I'll come back to you, Nancy, in a moment. So when we start to look at experience throughout life, day to day even, there's a range of experience. There's the positive experience that go on through the day. There's things that we feel fairly neutral about or don't emotionally respond too much. Then there can be negative experiences. And in that, this realm of emotion that we operate in, traumatizing and being traumatized has become a word thrown around quite frequently. And it comes with extreme negative emotion. There are people that are resilient that go through absolutely horrific events that do not become traumatized. The key attribute that the research we're going to talk about is was there a caregiver or somebody that is in a protective adult role in a space of that child that they're able to go to and be responded to in a supportive way is one of the number one ways that trauma actually becomes an experience for a person. We can go through terrifying experiences even and not be traumatized. The key element of trauma is that there's residual lasting impact that affects a person's life. And we're going to talk about that tonight in terms of in the nervous system. Many people that go through early childhood events might have forms of resilience or support of individuals in their life that support them through that journey, and it doesn't lead to residual or long-lasting impact. If they don't have that, I love in one of the lectures that me and Gabby were giving together, the concept that all trauma lives in aloneness. Gabby introduced me to that concept that all trauma lives in aloneness. Yes, things can be scary. We can even be powerless and still not be traumatized. The key element is the aloneness of going through it, especially as a child, and embodying and retaining and holding this physiology, this stress in our body internally, and it being built up throughout time. Then it having a negative impact throughout time is how we start to define trauma. We're going to take a deeper look at that. Dr. Robert Scare, his work, The Body Bears the Burden, was written way before The Body Keeps the Score, for those of you who are familiar with Bessel's work. The Trauma Spectrum book was a contribution of looking at trauma through a much wider time frame and lens with individuals. He really introduced us to the world. I had a wonderful dinner with Robert Scare. I think it was a year or two before he passed away, and he was still quite passionate about his work, spending more time with his grandkids at the time. But we had a conversation about this spectrum of experience, hidden wounds that are long ago in our lives are the foundational element of building up in this spectrum of traumatic experience to now having trauma abreaction or stress in our lives. A great contribution on his part, and the idea that the body bears and holds on to this information was something he introduced a long time ago. Bessel's work and one of the leading books in this century, really, around the body keeps the score, and the idea that the body holds on to these things, and it all stores up. That can be in a wide range of traumatic experience, and we're going to break that down to share with you a little bit about somebody on that spectrum of emotional experience. Fear response. This is what happens when somebody is going along and gets frightened. This individual, this is a young lady, I have her hooked up on heart rate variation stress testing, and she is pretty stable. She has a healthy nervous system. She's able to self-regulate. And a funny story is that we were in the wilderness when I was testing her, and a spider jumped and swung down onto my screen in the middle of my screen while we were testing. And that's what this big sympathetic arousal, big frightening, explosive energy in her nervous system looked like. The difference for her and for people with developmental trauma will be outlined more in a moment, but she was able to quickly return to a baseline of stability. This is how we start to differentiate people when it comes to a stressed nervous system, to have flexibility, for the nervous system to flex back out of a stress response of something that frightens us, even terrifies us. This young lady was pretty terrified of spiders. Her heart rate capped out at above 140 beats per minute, which is a pretty big scare. But she quickly returns back with flexibility back to her nervous system and stability. In this, our brain has these elements of this is a slide from the Institute of Heart Math, I should mention, that it doesn't measure the size of the threat. Any threat that comes in that we've had previous experience with or memories from activates our nervous system, and the emotional perception. This is where I have concerns about the labeling of big T's and little t's, big traumas and little traumas, if you haven't heard of that before. Is that the nervous system really activates in such a way that it's reactionary, equal to the size of the dog doesn't really matter. At that point, the nervous system reacts in that process. It doesn't think through it, it responds. So starting to look at standard trauma responses, and most of you are familiar with these: fight, flight, freeze. I do differentiate to collapse response and hyperarousal responses. I tear those down much more deeply in the course. But in that, this is a manifestation, and that looks a lot, can be extreme depression. Extreme shame responses fall in the collapse spectrum. And this is an image here, a part in the graphic image of somebody who has given up. Their body has given up and collapsed into surrendering towards death, even though that gazelle is still very alive. One to highlight when it comes to developmental trauma, um, people are talking about fawning response now, and that's important, right? In this situation, this fawn has an authentic bond, and it's bonded to the mother as a protector, right? This fawn is hiding behind the doe, and there's an authentic bond there. This is very different than a household where a child grows up terrorized by a caregiver who is aggressive in nature. This is a P's response. So this is an alpha wolf and a sub-alpha bowing down to the alpha wolf, who has already pinned another wolf in the pack down. So there's an aggressor in the space, and a sub-alpha will come up, bow their head like that, show affection to the alpha wolf. This is a way of surviving in threatening situations. Appeasement response is very different than fawning. The baseline of fawning is an authentic sense of connection. The difference in appeasement response is that underlying sense of fear or even terror, and I'll show a bond to you to survive the situation. So people that grow up in an alcoholic household will often ask themselves, why would I get my father a beer, knowing that in 5 beers from now he's going to get aggressive and attack somebody in the house? Because they were surviving in that moment. They were appeasing the aggressor at that moment from a state of fear. So some differentiations of things that to look at, and people that are survivors of childhood trauma can very easily appease therapists and clinicians and snow them in their process. A key attribute here is that tongue. You can barely see it in that picture, but that tongue is about to come out and lick the side of the face of the alpha. It's a sign of affection, but the underlying physiology of that subalpha is not actually authentic bond, it's fear. If we measure the nervous system, we would see that response. And there's a more subtle picture of what happens with subalphas or those around a alpha aggressive presence. Children will do this in a household to survive. Another trauma response we talk about, this was introduced to me by Elder Gene Dinauk, is friending. To actually make authentic bonds and relationships with those around us, and even to make relations with our trauma. That's how trauma actually heals. We step towards it. Now, a natural attribute of trauma is to turn away from avoidance of it. And when we turn towards it, this is how we actually heal it. I talked about that in a Facebook Live this morning. To show you some collapse states, this is a shame response for a person who's feeling very shameful about their relapse in alcohol and drug use. This is the collapse response. This is a person, me and my colleague Josh Dellahan are writing an entire training right now on shame, which we labeled the land between the living and dying, which this person, when they have a shame response, doesn't come back fully back to life. They are trapped at a lower functioning level, even though I was relating with her and talking with her in a caring and kind and empathetic way. Her nervous system was heavily compromised by the experience of thinking about alcohol and drug relapse. So shame is an attack on oneself. Another key attribute, we spend much more time in the pre-course in that way around what shame response is and what that looks like. I'm going to fast forward a little bit and get to some research here that starts to differentiate some of these things. To show you a picture before we go into some of this research, this is a post-traumatic stress disorder flashback. The post-traumatic stress disorder flashback is this person has sympathetic arousal kind of dominant in their nervous system, and they have a flashback, and the nervous system elevates extremely high. This young man elevated to 160 beats per minute instantaneously. He actually had a recall of a memory of being choked. In that, his nervous system has this flash of information from an event he went through, and then it tries to pull itself back down. It tries to pull itself back into a place of stability. And it's able to do so over the span of about 4 minutes. He's able to attain self-regulation. And right here, he's actually using a self-regulation technique. Again, post-traumatic stress is an experience where there are capsules of physiology that are trapped in a body in flash, but often can be worked through. This individual had some self-regulation capability and have a specific memory to treat. If we work with post-traumatic stress, there's specific memory here of him being choked is something that we can use a memory-oriented form of therapeutic work on. When we start to now hedge towards developmental trauma, it looks very differently. But I'm going to skip that. So PTSD being on, when we start to look at trauma specifically, PTSD has very specific triggers oriented towards it and often specific memories. Complex trauma will have a complexity of maybe many memories, but it's fluctuating in its experience. And these individuals may have throughout time found different ways to stabilize or had stability on and off. In developmental trauma, a term that was introduced to the therapeutic world by David Grant from Brain Spotting is the 24-hour flashback, a state of hyper vigilance that's continuous. And the research, what we're going to walk through, really spells this out. These are different manifestations from each other. A nervous system that is bathed in childhood trauma and literally built and founded in its development based upon developmental trauma experiences stays in a state of hypervigilance and doesn't come out. These forms of dysregulation, instability in the nervous system, I'll be walking through them here in a moment. So when we start to look at this PTSD, I showed a fear response earlier. Now we have PTSD response. Complex trauma can look very similar to PTSD with flashes and instability and even longer term states of instability. However, when you assess and look at it carefully, oftentimes there have been different times of stability or attachment-based relationships that have been there and existed in their life. It's been the stacking of trauma, that trauma spectrum that Robert Scare talks about, has stacked up enough that it's pretty steady and invasive in their life. Developmental trauma is a nervous system that has literally been bathed in stress experience. This is a very different manifestation. When we look at the HR results, you're going to see that. Um, so this is some snippets from me and Joseph Spinazzola's campaign to heal childhood trauma that I share here. So I always give him credit. He is now at the Foundation House. They have some good publications that are out there. There's still some new assessment tools that their team has come out with and things like that. I always encourage you to look towards his work. Very potent work. He has a publication out there, treating adult survivors of childhood emotional abuse and neglect. And I always give credit to where the credit is due. He is really well-versed in the research and been so involved in research teams that examining and tearing this apart in a way I never was. And us working together as how a lot of this information came to be, us pulling it apart. What the research showed very quickly for them is that PTSD was like a tip of an iceberg. It had these attributes, and in that, the total trauma response, this foundation of this iceberg, when you differentiate PTSD and you start to look at childhood trauma, the iceberg being an entire foundation of a nervous system that's been, that trauma responses are much wider than we even recognize often and commonly misdiagnosed. We're going to take a look at that. One of the key studies in this, is the unseen wound studies. And this was an examination of 5,616 youth. And in that, they were looking in specific categories. There's lots of forms of developmental trauma. Some of the assessment tools we teach in our course and things like that are far more comprehensive of pulling that apart. But for the element of studying it, they had to narrow down, their subject size. And in that, they looked at psychological maltreatment, so emotional neglect, emotional abuse, sexual maltreatment, and then physical maltreatment. So those were the main categories of where they examined and looked at what was happening in these research categories when they narrowed it down even more. So there's another study I talk about, and I don't have time to talk about tonight, where they took this down and broke it down into 1,600. I'm sorry, I do have it here. This study was a narrowed version. So they took the National Childhood Traumatic Stress Network's survey results and narrowed them down to 1,600. And so this is a publication by Joseph and their team where they pulled apart the attributes of symptomology for these 1,600 people. So interestingly enough, PTSD criteria fell way down on this list. It's not even in the top 10, you all. So the symptomology that builds the category of post-traumatic stress disorder is not even in the top 10 when they look at this. So looking closely at a handful of these, we can take a look here. Emotional dysregulation or affect dysregulation, the inability to control emotions, number one. Number two, attention and concentration dysregulation, and just slightly down from emotional regulation. Wow, it starts to sound awfully quickly like ADHD. Number three, negative self-image. So a negative view of oneself, also often right in co-occurrence with shame. Impulse control, number four. Aggression, number five. We start to see a drop after aggression. Somatization, clinginess, conduct or ODD, conduct disorder kinds of things, sexual problems. There's about your top 10. PTSD criteria didn't even fall in the top 10, you all. So in that, when they pulled this research apart and looked at it, these were the forms of symptoms that were not being directly addressed. Often people would be trying to treat developmental trauma from a PTSD perspective, looking very directly and focused on the attributes of PTSD, and all these other attributes being the highest symptomology would be left behind. Our trauma treatment model, the lack of the diagnosis of developmental trauma disorder, has perpetuated part of this process of people being labeled with PTSD and then being treated with a memory-oriented process for PTSD, and these other elements not being addressed. And that's why people with developmental trauma have had a very hard time finding healing, and even therapeutic models oriented to heal this have missed a large majority of these attributes. Let me pause there for a moment. I know we've had a couple questions, a couple in the chat, and just putting this initial information out there before we tear this down even a little bit more tonight. I know, Nancy, you had your hand up at one point. I don't know if you put it back down. Maybe I answered your question or not. Um,
I actually raised my hand accidentally.
okay.
But so far, this information has been very, very interesting to me.
Yeah.
And especially the fact that developmental trauma is treated totally differently in comparison to PTSD. Has a different approach. Is very interesting to me.
Yeah, the missing of this information has incredible consequences, right? It leads to ineffective healing, right? And so people that go for help with developmental trauma often come out, can even look worse, and or very short-term lasting results. Aaron, are there any questions in the chat bar to address?
So Evie, do you want to say your question out loud, or would you like me to read it? Okay, Evie has asked that I read it. So she says, just to clarify, can someone have both CPTSD and developmental trauma? And if so, how is that treated?
So when you look at the nervous system, most people would say, they look very similar. When you look at the nervous system, we're going to show, I think I have the results coming up on developmental trauma. There's definitely a difference. Now, when you're looking at CPTSD and developmental trauma, the attributes of some of these things can be in CPTSD too. The difference is the timing, the immersion, and when you start to assess it, that there will be remarkable differences. When you use some of the tools that we introduced in our trainings that are assessment tools specific to developmental trauma, you'll start to see a separation that starts to occur there. Now, CPTSD, in terms of it being the same or different, a lot of times CPTSD will be a stack up of experiences, even in an adult life, that will lead to a fluctuating reaction in an unpredictable nervous system. When we start to talk specific to childhood trauma, where developmental trauma it arises from, there's a shift in that. It can be a certain kind of immersion for a number of years, and a person can walk out of and literally be placed in a non-traumatizing household. And there's some research we're going to present here that it all shows up again, even in adulthood. It resurges commonly. And so CPTSD, when you look at the criteria of it and start to tear it down, even the attributes of how they diagnose this, there's some overlap there. And so if we were looking at diagnosis wise, would they overlap? Yes, very possibly. Could they look the same, or would it be difficult to tell them apart? Yes, but when you start to get really specifically dialed on developmental trauma, these criteria, you start to use assessment tools specific for developmental trauma, you will often see a separation in the pack there in these two forms of labeling of diagnosis. In the end, the nervous system is compromised very similarly, except developmental trauma often can be formulated in non-verbal years and even very difficult to work from a memory perspective. CPTSD, oftentimes you can work to expose memories. Developmental trauma can be very difficult to do that with. So those are some of the differences there. I hope that helps you. You're on mute there, Aaron. I think you're trying to.
Whoops. KB, you're up next if you'd like to read it out loud, or if not, I'll read it for you. And Evie says yes, thank you. Okay, I will go ahead and read it. Can you please speak to some of the evidence-based interventions to use for healing developmental trauma?
Yes, we'll talk a little bit more towards the end of that. And I also have some opinions about the concept of evidence-based practice that I share about regularly in more of my personal feeds and websites, etc. But we can look towards that and have a conversation about that towards the end. I might share some quotes for you around some of that too.
Oh, we have one more.
Oh, we do? Okay.
Yes, so Robin wrote, as developmental trauma disorder is still not recognized in the DSM by my understanding, do you use the diagnosis as CPTSD? Also, is the Spinozzola book appropriate for treating developmental trauma disorder?
So to pull that apart, so CPTSD is the commonly used diagnosis that people use in place of developmental trauma disorder. The only problem that does is it enables the system to continue to refuse at the issue. So for years of working with clinicians, etc., and this was the encouragement actually by a number of the parties that were involved in this research, encouraged people to, it was a proposed diagnosis. So in that, if you do put CPTSD, but you already know it's developmental trauma, instead of enabling an unhealthy system that's not looking at this diagnosis seriously enough, putting in it secondary diagnosis, developmental trauma disorder, and in parentheses, proposed. So it starts to force people to take a look or look at what that even is and search the information. Insurance companies, reviewers, next professionals, often when we put that down, instead of avoiding putting anything down about developmental trauma, putting that in place forces people to have to look towards this information I'm presenting to you right here. And it's out there. It's on the internet. You can look it up. And in that, that was the initial response to the refusal to accept the diagnosis was that it's a proposed diagnosis. So it's under review, basically, and awaiting further research. And in that, we're referencing a higher awareness, at least in our diagnosis process. So when it comes to diagnosis, being able to push that and being able to reference that to the world around us and educate our clients, most importantly, and educate our communities on the differences, because a large frequency of people continuing to push PTSD information in populations that need to learn about developmental trauma. I did an event with a veterans group two of them in a row, actually, a radio show, and it's in DTTI's Facebook page if you're looking for want to look for the link, where I talked about the common precursor to war trauma is often developmental trauma. And we had a really intense panel and discussion on the Pine Ridge Reservation with the Akichita Veterans Center about that. So it's important for us to, if we have to do that diagnosis to get approved to treat, so be it, but to put the proposed diagnosis down and most importantly, make sure that the client knows this information so that people can get wiser to what we're working with and how we work with it. I missed the second part of that question there, Aaron, I think.
The second part of the question is the Spinazzola book appropriate for treating developmental trauma?
Yeah, he definitely, when they were publishing and working on that book, a number of the people that were a part of publishing that book were a part of of a lot of this research. So there is some good nuggets in there, and I always encourage people to take a close look at that book.
And then, Steve, if you want, I can share the one-pagers that we have of the other specified trauma and stressor-related disorder, which people would then say specify developmental trauma.
Yeah, let's want to make sure we have enough time to cover some of this material. Let's see if we maybe have some time to come back to that. Yeah.
Okay. And then there's one more quick question. Is there access to DT assessments like the ACE, for example, is readily available? Yes.
So, yes, it's widely available. I do have my concerns about the evaluations that are being done currently in a lot of places. To take, for example, the ACEs questionnaire, we wouldn't even be looking at all this information if it wasn't for some of that research. So assessing it is highly important. But for example, the ACEs questionnaire, 10 of the most horrific things you can possibly go through in childhood, to hand that to an individual and have them fill that out is extremely stressful. A lot of clinics will literally put that in their intake paperwork and have a person filling that alone in their waiting area. And this is very common, not to pick on California, Aaron, but their
Pick away, it's fine.
Their Medicaid system reimburses $25 for every ACEs questionnaire that's completed in intake paperwork. So people are throwing this literally into that person's hands and setting them into a waiting area to recall the 10 worst things you could go through in your life alone in a waiting area one by one. I always share a story of a woman that went through that process who, had went in for help and asked if she could talk through it with her therapist first, and they refused to let her in to see her therapist until she completed it. And she threw the clipboard across the counter and walked out, never to get help. I ran into her in a workshop down the road where she learned a lot of this information, actually. But so assessment is important. But when we're looking at all trauma lives in aloneness, and particularly developmental trauma lives in aloneness when it comes to authority figures and caregivers in a person's life, to do that alone is not trauma responsive care, it's trauma inducing care. So it forces people to have to use trauma adaptations before they even walk in the office to meet with a therapist. So in that, I always recommend that any of these assessments are walked through within the window of tolerance, a person's ability to manage the stress of the questions, and not have to start to use trauma adaptations to just answer a question. And some people, they can only do 2 or 3 questions into that. There's another tool that we introduce and walk through in the foundations course, which is even more extensive. But we clearly delineate that should be done with somebody and not alone, and gone through. And in that, I'm always, when it comes to assessments, I'm far less interested in the score than the information that we achieve by working through some of these questions. I've been in a lot of places where even the ACEs scores, a person with a score of 2 that has extreme trauma abreaction weighs themselves against a person who has a full 10, and And in that, Gabber has a great quote in his book that there's no rhyme or reason for comparing one's suffering. We all carry our wounds in our own individual ways. That's from the myth of normal. And so, assessment is valuable, and these tools can start to pull that apart. So I just really have to, that's a pedestal item for me to jump on a pedestal about, which is be very cautious with assessment and being very responsive to people as they're working through it, and certainly not filling out those kinds of questionnaires sitting anywhere alone. So I'll leave it at that. So a lot of the mental health world, relies on diagnosis. And so in that, what you label me, individuals with developmental trauma will commonly have many, many labels of diagnoses. They'll meet criteria for a full basket full. And when you look at all those key symptoms that I listed there, you could see why they could, in that alone could meet, probably 6 to 7 diagnoses by going across those list of symptoms. And so labeling that process, of labeling and diagnosis has a lot of implications for this population. If you ask a population of somebody who's developmentally traumatized, sometimes they'll say like, I didn't have any trauma. I had a rough childhood, but I don't have trauma. And that's the resilient side speaking, that they went through that process, but it also can be of a blindness speaking too. And so I just always put this in here that we get very mindful about these labels, like labels of PTSD, CPTSD, as you were asking about the difference between that and developmental trauma. If you have to diagnose for your line of work, that's fine in that process, but to be very mindful, a lot of these people have been labeled literally their entire lives, and that we're very sensitive and mindful of that. That's why I put the slide in here before we kind of move on in our discussion points. So I just flashed this up here quickly. They actually, as they were looking at the criteria for developmental trauma disorder, they found that attachment disruption proceeded as an indicator above traumatic victimization, meaning I've been through a lot of events and have a whole list of them. If that's paired with attachment disruptions, and attachment disruption is a tricky thing to pin down, because it could have been that somebody left for a long term in a childhood, an attachment figure. It could have been that somebody passed away. It could have been that they were adopted out or placed in a foster home. There's lots of forms of attachment disruption, but a caregiver that's being very reactive and victimizing, that by itself can be attachment disruption too. So, but in that, the outcome and one of the things that astounded them the most in the research was the bad things that happen against the backdrop of all the good things that did not happen. So when we look at developmental trauma, that the backdrop on all of this was, were there good things happening? Were there attachment figures? Were there supportive people? Were there individuals that stepped in and checked on them or tried to protect them? Were there people that just identified that they were struggling? It can be a teacher at school. When bad things are happening as a child, when a person is responsive, any adult that child can trust has some attachment influence there, that this often can really shift the onset of developmental trauma disorder symptoms, or these symptoms as we label as a disorder. So attachment presence, a caregiver, an adult figure that's very responsive to them, has the ability to influence all this. They found this to be the #1 criteria above and beyond the traumatic victimization. The number of events you went through was secondary to that person that was there to support you. This shows how powerful our attachment pathway is, and And in that, conflicted attachments can lead to a lot of things. We're not going to spend a lot of time on different attachment styles tonight, but in that, the research was really clear that they put this above and beyond. If there was attachment disruption in the process, that this was the louder indicator that those symptoms would kick off, and then the amount of traumatic victimization a person went through. Kind of shocking for a lot of people to hear that. Person could go through an extremely reactive and even violent childhood, but if there's somebody there that is very present and caregiving and trying to protect them, that some of these symptomologies will not show themselves.
Can I jump in real quick for 1 sec?
Yep.
So attachment disruption also includes neglect.
Yes.
So I
Yes.
just want to name that. There's not necessarily a before and after if there's a chronically neglectful household.
Yeah. And I just flash this up here quickly to show, that attachment disruption is such a loud contributor, that 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 over the top of being victimized in any of those ways that we listed in the studies, were quite a few percent above if they had that attachment disruption. When you put them both together, that's where we see massive impact. So that process, of developing developmental trauma, that attachment disruption is one of the key things that we are looking for. And by the way, for your question about differentiating CPTSD and having both in developmental trauma, that's one place that you can start to look in terms of differentiating one or the other, or one more than the other, is attachment disruption in the process. So it's been proposed, developmental trauma disorder was proposed as a clinical framework as a sequel of the complex trauma exposure in children, right? To really tear that down and look at that difference and being able to precede complex trauma for some people. I'm going to skip the study and move on to this part of the story. When we're starting to try to pull apart PTSD and developmental trauma disorder, you have a traumatic event or series of events for PTSD, and you see the list of the criteria: intrusion, re-experiencing, avoidance symptoms, negative alterations in mood and cognitions, and increased arousal symptoms. In developmental trauma disorder, you have a lifetime of contemporaneous exposure. So there's a continuous on and off exposures in the earlier developmental stages of life. And their criteria all share one word: dysregulation. Affect dysregulation, somatic dysregulation, attentional dysregulation, behavioral dysregulation, self-dysregulation, and relational dysregulation. These are all specific forms in which the nervous system is aggravated, and it can be a combination, all of them. It can be a handful of them. But in the end, the key word that is the attribute of developmental trauma disorder is dysregulation, a nervous system that doesn't regulate itself and often never finds regulation. So that instability that's in the nervous system can show itself in these forms. And we'll take some more time on those as we kind of break them down. I want to also highlight something before we break those 6 forms down. Is the other attribute of that research in that last study was that these are, the yellow is the childhood trauma exposure victimization, and then blue is when symptoms showed themselves. One of the interesting things they found in this specific research to developmental trauma is what they called landmines. The physiology of the traumatic experience being held and survived, and then a trajectory that later on in life, some combination of elements, just like a landmine, the vehicle, the boat has to be going right at the right path, and it hits this physiology and it explodes. that there's a time delay process for symptoms in the majority of developmental trauma survivors. Not only that, one of the more interesting elements of this was that if you look at the age of onset of symptomology, over 50% of these individuals this was specific to sexual abuse, their symptomology showed up in young adulthood. So 50%, it's a time delay of surviving childhood trauma, and then it's showing up in their adult life. For people that come in, and for those of your mental health providers and practitioners, so often will come in and be like, I don't understand why I'm having a hard time now. I went through some stuff when I was a kid, right? And now I'm struggling. What is going on? 50% of people that survived childhood sexual abuse showed the symptomology in young adulthood. This is really, really important, you all. This is a not known fact. And also just the time delay in the majority of these cases that you see, that these symptoms of developmental trauma are delayed in their onset. And so we, for the years we worked with, developmental trauma and teens and young adults, it was so commonly apparent is like, yeah, they went through stuff when they were a kid, but like, why are they struggling now? And that is the norm. The norm is delayed onset, a very key finding from childhood traumatic experience. The research was conclusive in this, and it's something that really people need to know, to be informed about, that it's not uncommon that it shows up later in life. And you can theorize a lot of things, going into adulthood and being on their own potentially, partnerships with other people that can activate these things. But across the board, delayed onset, if it was in teen years, a lot of them were even towards later in teen years and then into adulthood. So just something to know about and to be aware of, that the research showed us, that really shows that we have to be diligent in understanding that when people come in and we're assessing and working with people that are having forms of these symptoms, these 6 forms of dysregulation, that it has been directly shown that early childhood experience is driving that bus. That's difficult for people to sometimes hear, because we're in the here and now. I'm struggling right here and right now, and I want to know why I'm struggling right here and right now. And then we go back and want to assess childhood, and people, the natural element of childhood trauma is to turn away from it, right? To put it in the past and want to move on. But when people come in to get help and they have symptomology, this is the source. No, we're on to the next part of this story. So how does this work in the nervous system? And then we'll go back to the 6 forms of dysregulation. When a child is born into the world, it's born with needs, and they're needs that we cannot meet, right? That's where parents, caregivers, etc., play the role. A baby can't feed itself. It has to be fed. So a baby comes in the world with a high level of need, and the nervous system arouses behind that need. That's where a baby goes from being fussy, then to starting to be a light cry to hysterical cry. If they're hungry, they get fussy. An attuned parent responds and says, oh, you're getting hungry, feeds them, either breastfeeds them or gives them a bottle. And in that, the nervous system experiences gratification because the attuned caregiver responded accurately. They got what they needed, and the nervous system calms down. This is the raw element of trust. This is the basis of where trust is built in the nervous system, by experiencing that over and over again early in life, that as a child, my nervous system gets aroused, a caregiver attunes, it decreases the arousal, and then what? Relationship becomes trustworthy and something that helps calm me down. When a child is in a household where their needs are not being met regularly or on and off or intermittently, and a caregiver is maybe compromised, maybe they're substance abusing, maybe they're overworking, maybe they're not present in the individual's life, they're being raised in a child care situation, and that place isn't as attuned as maybe they need to, maybe too many children in there, etc. The experience of having an attuned caregiver respond to them is compromised. And in that, when we don't get our needs met, the nervous system arouses in an upward trend. It aggravates, it activates. So we're going to look at some results of that here in a little bit. That arousal in the nervous system, that aggravation in the nervous system doesn't get met by human compassion and giving. So therefore, relationships become unpredictable. They become actually aggravating. By the time a caregiver is responding when I'm in a hysterical cry every single time, my nervous system is building around this high level of aggravation, this high sympathetic arousal, this high reactivity. And that is where the source of this dysregulation comes from. So when we're talking about a baby, right? When there's a storm and a caregiver comes and responds with their calm and their need, this develops the concept of co-regulation, how relationships calm us down, how I talk to my friend, they help me feel better. For individuals that are never met with calm, maybe parents are highly aggravated and activated themselves and stressed, the baby cries, the parent starts hollering and yelling at the baby or the child who wants something, just walks in the room and says, Mama, I'm hungry, or Daddy, I'm hungry, and they're met with, hollering or yelling or reactivity, or there's violence in the household where there's no calm, this co-regulation experience never gets built. The foundation of it isn't installed as an experience, and therefore trust is limited. So is connection. This is the foundation of the attachment pathway of sensing connection to anything in the world around us, including walking out in nature and feeling connected to something, feeling connected to other people, feeling connected to our pets can be compromised. Actually felt sense of connection. The experience of that is built, the sense of connection is built through that attachment pathway. And it's by meeting these experiences that are gratifying in relationship and calming that connection in that pathway of seeking connection and sensing connection is developed. Eye gazing from mother was one of the slides that was just back there, and I had to move along. So we're looking at a different structure when we're experiencing developmental trauma. You have a need, the arousal goes up, and then you have an unattuned caregiver. So they don't have the capacity to respond accurately. So for example, even though many of us did this, if you're a parent on here, the baby gets fussy and they're actually hungry, but we think they need a diaper change. So we change the diaper. What happens? The fussy gets louder. No, you didn't hear me accurately. I wanted to eat. So in that, a parent can, an unhealthy parent can get reactive in that time frame and start to react because they tried something and then it didn't work and then they're not attuned. So then I'm now reacting to the child's arousal. So this storm gets met with another storm. What happens in that? Increased arousal. So now we have two storms meeting each other, which just causes the baby to cry at the highest level of sympathetic arousal. And this happening over and over again in an unattuned way. And let's take that and let's make it not about feeding. Being in a household and coming home from school and wanting to talk to somebody when they're really young and talk about their day at school, but it was really stressful, a parent that's not available to calm that storm for them. All of these build arousal into the nervous system, and we're going to look at a slide about that. And in that, this sense of aloneness, nobody gets me. Nobody cares about me. The underlying belief of mistrust of the world around here, which is nobody is good, right? I've seen pictures of people with a t-shirt on that says, trust no one, right? What a way to exist in the world, to live with absolute mistrust of everyone. That individual, if I assessed them, would probably have early childhood trauma. They've never had a trusting relationship. So when there's unattuned caregivers, whatever that is, that can be substance abuse compromised, that could be a rageful parent, it can be a parent that's mental health compromised, in deep dark depression, that can't respond to a child. It can be a lot of things. This builds into the nervous system as increased arousal. Those six forms of dysregulation are sourced by this ongoing dosing of the nervous system not being able to be calmed down. And the component underneath that, the foundation underneath that, is I'm alone in the world around me. These individuals become very self-centered in nature because I can't rely on anybody else. I have to do things myself. This baseline of mistrust now permeates every relationship they have. They can find somebody they're attracted to and want to be in a relationship in, but when they get into that relationship, the foundation in the nervous system is still mistrust. So they're suspicious, they're anxious, and these formulate some of our attachment styles that some of you may already know about. Let me pause there for a moment, just see if there's any questions. I saw
There's
the
a
chat.
couple of comments. Oh, go ahead.
I saw there was the chat bar was increasing rapidly, so I had to make sure I stopped for a moment.
Yes, there were a couple of good sort of mini discussions in the chat. Tonio, and forgive me if I'm saying your name wrong, said we're actually missing the most valuable data by not doing any assessment, by being present, even the PHQ-9 or GAD-7, by being present with the client patient and observing or supporting them and filling those out. I've done this in helping me decolonize the assessments, which is fantastic. KB wrote, sounds like giving ACE without the safe space to complete it, etc., is not trauma-informed care. I had to complete some in college a few times. That was also not the right space. Uh-huh.
Yeah.
Jermaine asked, is there an age range for the developmental trauma disorder diagnosis? And I said, I responded with the criteria have to be met within the developmental years, 0 to 18, but it can absolutely be identified in adulthood.
Yeah.
On one of the slides, Nancy asked what the gray color was representing. So I think that might have been the underwater landmines one.
Yeah.
The relationship between age of experience of childhood sexual abuse and onset of depression. That one.
Yeah. So it's just before the underwater landmines.
Got it. Yeah, I'll go back to that quick.
This one, yes.
That's post. I think that's completion of the assessment process there. They're not going on in time from there. It's the first time I ever asked that question. I presented that in a lot of places.
And then Evie, in the conversation about, you know, diagnosis and assessment, wrote, to clarify, I am not a fan of labels, so I absolutely agree with what was said. I was just curious because of being mislabeled myself and having to endure multiple assessments. And my response there was, I'm sorry to hear that you've had that experience. It's way too common, especially in developmental trauma folks, unfortunately. And then Robin wrote
I think
to me that,
look at
go ahead.
question. I just want to make sure we just look at question. I appreciate all the comments. I just want to make sure that we use our time wisely. Is there other
Yeah,
questions?
we don't have any more questions in the chat, so if folks want to add more,
Yep.
or if somebody wants to raise their hand.
Yep. We can do that. While you're formulating those, I'll take a moment and move through just a couple more slides, and then we're going to have time to really just have discussion. I want to invite discussion for people to step into discussion.
Sounds good.
So this is what we're talking about, you all. This is the heart rate variation test for a teen with all the criteria of developmental trauma disorder, and their nervous system is all over the map. Red means that it is very difficult to measure. It means that the measurement device is having a hard time with how up and down and chaotic the nervous system is to even measure it. And this is a very sensitive device. So you'll see trends of down, and this is across a test of 6-7 minutes, the nervous system being way down in baseline of heart rate, and then way up, and then middle ground. And you see these trends of areas. If we were to go through here, we have down, then a little spike, but then a big spike, then down again. The sympathetic arousal is trying to calm the nervous system down, but then it's conflicted with big sympathetic spikes again in here, and it's literally chaos. The nervous system is very hard on the gas and on the brake at the same time. And it's literally like if you got in a car and jammed on a gas as hard as you can and hold the brake down, how much the engine is revving and fighting itself of trying to stop. And what that does to the nervous system in terms of the outcome of that is what leads to these 6 forms of dysregulation. The inability to stabilize with a lot of things. So this is a measured attribute of the outcome of those forms of dysregulation or the source of it. And so I want to take a moment and just spend the remainder of our time talking about these. And so, and a little bit about the why. So one of the higher rated elements was attentional dysregulation. And so often individuals with a childhood trauma diagnosis or history will be medicated even for ADHD. And it's not uncommon for people with childhood trauma to have a very opposite impact from stimulant medications in terms of reactivity and inefficient treatment. This is also something for the professionals that are on here to take a look at and carefully pay attention to. In that attentional dysregulation is a state of hypervigilance in the nervous system. So I'll use kind of a funny example that people use often for ADHD, squirrel. The mind is here right now with you, and then it gets diverted to check something that moves. A squirrel, there's something else over there. There's some other stimulus over here. I have to check it. So it's checking things for safety on a very regimented basis. So people are easily distractible with childhood trauma because they're externalized and hypervigilant to the outside world and what's happening around them because of volatility from caregivers, violence in a household or a community, etc. So now my attention is always checking. I'm checking to make sure I'm all right. So many people will view this through this lens, right, of distractibility. Is it distractibility or is it hypersensitivity? To check things outside of me to make sure I'm all right. So when you look and study people, and I've worked with thousands of developmental trauma people like I have, many of them are checking doors, sounds, those kinds of things for environmental safety factors constantly. And so their ability to hold their focus on one thing when they hear a sound, what's that, is a safety check. And it's a hypervigilant system of safety to make sure that nothing out on the outside world is going to harm me. It's a very self-protective pattern of protection we talk about a lot. Affect dysregulation was number 1 on that symptomology list, meaning that the moods, emotionality is inconsistent. It's up and down. You can have a conversation, things are going pretty well for the day, and then they just right away take a turn in a very negative direction, whatever that emotion is. That could be rage and anger, it could be a shift into sadness or despair. But in that emotionality and its instability of emotions changing throughout time, even without stimulus that's associated to it. It's one thing to get upset because something should have upsetted me. It's another thing to be sitting in an environment where not much is going on and then suddenly upset. So commonly, for example, people with developmental trauma in the educational setting, sitting in school for long periods of time, they're working on schoolwork, etc. And this is not coming from a place of neural divergence and struggle from that way. I'm not suggesting that, but suddenly their mood is just shifts so dramatically as they're sitting there and they can't assign a rhyme or a reason. And so the moods are inconsistent, tough to map, up and down. Individuals like this will not, they'll wake up one day and feel like they're having a great day. And then 3 days in a row, they wake up and it's like, this day is going to suck. I wake up terrible right from the get-go. Very inconsistent. And that's really driven. Emotions are a messenger in the nervous system for action. It's some Darwin talk there. And in that, the nervous system is moving constantly, much like the attentional dysregulation, but it's manifesting in these mood changes consistently. Somatic dysregulation, the body not being stable. The HRV result was a good example of that, where it's up and down, and the body doesn't really find an equilibrium. It also our experience with the body, sensing it, um, being connected to it, the reactivity towards any kinds of somatic sensation, sensitivity. Uh, the body is an up and down relationship with that individual. And so somatically, they can experience a whole myriad of things, even sensing their body, then being hypersensitive to their body, not feeling it, then over feeling it. Lots of manifestations there. And understanding that the body is actually holding this concept of this physiology, that 24-hour flashback I talked about, of being immersed and dipped in developmental trauma and then it being trapped and held inside there. And so it's like trying to contain a dragon in there with so much physiology moving and changing constantly. Self-dysregulation, the sense of self, um, focusing on oneself means that I'm not checking on the environment or the world around me being safe. So self-dysregulation, the sense of self is often compromised. It's actually built in that attachment pathway. And I usually talk about that more, but we're kind of moving along for tonight. That self-dysregulation, that process of dysregulation of how I am as a person, as myself, sensing self, how I feel about myself. And in that, that can be an up and down journey for individuals. Liking themselves, even narcissistic tendencies come from often childhood trauma of inflated sense of self, and then pivoting to having deep underlying shame there. These are all forms of self-dysregulation. Relational dysregulation, being able to be in a relationship and have a steady experience with each other is compromised. Reactivity back and forth, the ability to feel safe in relationship, reactivity in relationship. There's lots of forms of relational dysregulation that we can take a look at. But in the end, intimacy and connection avoidance is a part of that self-protection mistrust baseline for individuals, that most relationships exist on a baseline of mistrust. So I'm good with you for a little bit, I feel connected, but then suddenly mistrusting in some way underneath that, or reacting in that relationship. And then behavioral dysregulation, people's ability to change their own behavior, even when determined. I'm trying to not act this way anymore, but I react. Reflexive responses are an attribute of childhood trauma. reflexive reactivity toward and things like addiction, unhealthy behaviors, saying, okay, I'm going to change this. I don't want to do this anymore. And then 5 minutes later, finding themselves doing it again. These are all forms of how behavioral dysregulation can manifest. So these are six of the most important criteria around developmental trauma. And if we're going to go towards disorder, I call these developmental trauma adaptations, the six main forms of trauma adaptations that the body and the brain and the person experiences. And these are all shown attributes and researched attributes of developmental trauma. So with that, with the time we have left, I want to make sure we have some time for more questions on these, and also come back and answer some of the question about treatment of developmental trauma.
So Jermaine asked, is there any overlap or link between developmental trauma disorder and Bruce Perry's NMT model?
So Bruce Perry's MFT model really does take a developmental lens approach. And so, in terms of working, in this neural sequential model of being able to um, uh, work on needs being met and nervous system attributes that come from that and working to regulate that area of the nervous system. So yes, there's an overlap there. I respect Bruce Perry and he actually is a big fan of heart math and uses a lot of heart math kind of teaching in his stuff and is a fan of the HRV work that heart math has produced over years. So the answer is yes, there's definitely some overlap there.
Great, thank you. Anyone else have questions?
We'll take a moment and go back to a question about evidence-based practices. First of all, the research has been pretty clear that this is very body-oriented. It's lives in the body, it is experienced in the body, it's physiology. And the other challenging thing with the healing of developmental trauma is that memory, particular kinds of memory, to actually memory recall can be challenging for people. So a lot of evidence-based practices are highly focused on cognitive processing and that kind of work, often not addressing the body. That said, there are more models that are integrated with the body, and there are some that are evidenced. If they meet the criteria for evidence-based practice, is a whole nother story. For example, the APA, just a few years back, eliminated acknowledgement of any therapies that included somatic focused work. When you consider the body keeps the score, the body bears the burden, the neuroscience of the midbrain and reflexive structures, and a lot more, and I can talk about that for a long time, to not acknowledge that the body needs to is not a practice in psychology or therapy for this, that for me is a big miss and a big misalignment. Um, and so that said, there has been open acknowledgement that oftentimes developmental trauma has been very difficult to work with EMDR. I trained, have worked with many trained clinicians, and part of the reason for that is that EMDR is really focused a lot on memory and working specific memories and manifestations of it, aka a target. And so there have been some adjustments to EMDR. There's some newer attachment focused forms of EMDR that are happening. But again, often these individuals will have 1,000 memories to work on. And in that, the physiology that lives in dysregulation ultimately has to be healed. Now, there were several elements that I talk about in more of the course that came out of the research, which is called the Maleficent Eight. Um, there are key areas that we need to address in treatment. And out of it, there are some things that are evidence-based that are shown to be more effective in some of that work. Animal-assisted therapies is one of them. That work and that process of that work and working in the patterns of the body and connection, I could stop my share now, um, uh, will often be a way to work in on accessing the physiology for individuals. I personally, and a lot of people that I just listed off as a lot of my mentors along the way are big fans of brain spotting and working with brain spotting on particularly developmental trauma. And that's why I wrote the developmental trauma model of brain spotting in response to this research, which is a very focused programming that works on physiology. Brain spotting is a very physiology-based technique and focus technique. And there's research out there, but it won't show up in the list of evidence-based practices. But there's lots of research out there, and there's been some very effective outcomes. So those are some of the examples of stuff to look at. If you have other ones that you have questions about, I'm familiar with lots of other models, but those are some of the common ones that come about. And developmental trauma presents some very challenging attributes to be able to treat because of the difficulty with a lot of memory-based work, the physical component of it, and so it has some unique attributes that make it more difficult to treat. So I hope that is helpful.
We have one comment that Robin says, I've found IFS to be helpful, brain spotting as well. So I thought you might want to take a moment to talk about that.
Yeah, sure. And so I respect IFS and aware of the work and in some of my trainings I lay out some of the structures that uh, embodiment is one of the most important parts that was found in this research, embodiment. And so the thing that and IFS has I know people have had some great results with it, etc. But embodiment of the physiology of childhood scared parts is often a missed part of that puzzle. And I in the 1.0 training I do, I really walk through a model of a physiological capsule where I discuss more of these things. So if people are using that model, it's the embodiment part of it and the integration of it is someplace where I've seen people lack in terms of utilizing that model of not using an integrative model or imaginary or visualization. In my trainings, I show slides of where visualization happens in the brain versus where this reflexive physiology lives. So those are just a couple of thoughts on that and things to to think about or consider. And there are people that have been using that and have had some good results.
Any other questions, folks?
I have a quick question. Since we're talking about IFS and also the disruption of early attachment. So, and this touch, you also mentioned about touch, Steve, that so for adults to heal the attachment wounds, thus the developmental trauma, how do you find most effective? Is it through the so-called the self, through IFS parts work, or there's some movement or some sensory motor integration?
Yeah, I have a pretty specific model of how we work with that. And some of the foundations course is how we get access to childhood physiology, right? I'm very focused on that. I don't use the IFS model. I use a different approach. Some somatic-based work is partially integrated with that, and I work to specifically find the physiology capsules of early childhood trauma and then brain spot them. So that's what the 1.0 and 2.0 programs are all about.
Thanks.
Good question.
Any other questions?
Lots of people off camera. Let's see who's all on here. You don't have to hide you all. You come on and say hi. So a couple things to wrap up then, if we're not seeing some more questions. Obvious attributes that are a key part of healing developmental trauma, if you're a person that's not out there, that's not a clinician or mental health worker, are the development of self-regulation. And the ability to regulate that nervous system takes a lot of work. It's about repeating the process, speaking of Bruce Perry, but in that to work with self-regulation, there's lots of things I've seen for people with developmental trauma where they have been able to access substantial healing for themselves. Things, like, simple things like free dive training has been profound for people that I know. But developing a form of self-regulation, horse work and horse therapy has been incredibly profound for many people. And I really do always recommend heart math techniques. There's a couple of great books out there. Transforming stress is a good one. Transforming depression, transforming anxiety, transforming anger, depending on how the developmental trauma dysregulation surfaces. There's a book for teens, Transforming Stress for Teens. I wrote the foreword in that book, and it's written in a teens language of school and assignments and peers and those kinds of things. There is the ability to work on oneself, and working to regulate a nervous system doesn't just happen in an hour session in a therapy office. To heal developmental trauma takes focused effort for the individual to work to re-regulate a nervous system. And the foundation of it being programmed with dysregulation, it requires a lot of discipline and self-work to do that. But for some simple solutions for individuals who might be on here, HeartMath's work is very simple. It's evidence-based practice for trauma, for anxiety, for ADHD, which means for some of these developmental trauma attributes of attentional dysregulation, etc. There are some wonderful opportunities in HeartMath's healing practices, and they're really simple and can really be utilized, by oneself to work and practice and use discipline with. So I always like to share that piece at the end for those of you that are not mental health clinicians and going to go through tons of training. That's a good place to start on working on establishing regulation in this dysregulated nervous system. So I think with that, if we don't have any questions left, we'll leave it at that, everybody. Lots of material there. Thank you for joining us, and I'm happy to see some of your names pop up here. Feel free, we'll be putting a recording out, and feel free to look ahead. We have the foundations course is going live in a month with cohorts that we work through some of this material even in a more detailed form, and 8 different assignments for self-discovery in that foundations course. All video recorded, and you can go through it on a self-study, or you can go through it, which is, if you're going to work on developmental trauma, it's good to have conversations with people about that. We also have supportive cohorts for people that are just public that want to address and look at their developmental trauma. And also we have cohorts that are for clinicians to take a deeper dive. That will be out next month. Watch for it as we release it. And we also have, for those that are brain spotting trained therapists, we have Digging Roots for Brain Spotters 1.0 and 2.0. I am building a 1.0 for non-brain spotting therapists for in the future with some of the technique that we use in that course that will be out in the next year or so here too. So thank you for supporting us and joining us and learning a little bit more. Thank you for your questions and your time and your beautiful evening. And, please follow us on social media and share our posts and our information so that people learn more about developmental trauma and how its manifestation is different from a lot of what's out there. Thank you, Nancy. Have a good evening, everyone.
Thank you so much. So rich.
Thanks, everyone.